There's some seats down here on the wall side. I'm pretty much ready, Tony. Okay, cool. We'll just leave the door open for one or two others, but I want to get started because we've got quite a full program. Welcome everybody to the second of this new series of Global Health History seminars on the theme of tropical diseases. Those of you who came a week or two ago will know that the format is slightly different from the previous year, in which we have two main speakers, one a historian on the subject and another presenting a public policy or overview of the particular disease in question. So I'm not going to waste too much time other than to say this is a pleasure again to welcome you all, and it's due in great part to the support of the Wellcome Trust and the Wellcome Trust Centre for the History of Medicine at UCL in London, personified here by Sanjoy Bhattacharya, who's going to be my co-chairman today, and also with the support of the Tropical Disease Research Special Programme and the Programme for Control of Neglected Tropical Diseases. One other thing that I would like to say is this is a first today. This is a unique event in the sense that we are presenting this as a webinar. So this is going to be available for anybody who's registered on a site who can watch the presentations and hear the presenters at their own computer. And this is the first time that we've tried to do this. My thanks to the initiative and enterprise of the ITT team, and particular Tony who's over here. So this is a first for them, and to those of you who are listening at your computers in whichever part of this building or whichever part of the world that you happen to be, you're most welcome. I'm now going to move straight on and introduce Sanjoy to come and in turn tell you a little bit about our two speakers, and then we'll move very much forward from there. Thank you.
Thank you all for joining us. I quickly want to thank different groupings within the WHO for their support for this event. I'm very, very grateful to the collaborating departments that Thompson has already mentioned, but I'd also like to thank KMS for their support, and Rob, Lorenzo, Elaine, Najib, and Human have been wonderful sources of support, but so has the Global Health Histories project and Thompson, so thank you very much. Last but not the least, I'm grateful to the library for giving us access to this wonderful room. It's much appreciated. And we'd like to thank our main sponsors, the Wellcome Trust, which has given us the bulk of the money, and my center, which has also contributed in major ways, which is the Wellcome Trust Center for the History of Medicine at UCL. Now, if I gave you a comprehensive review of Professor Anne Marie Moulin's accomplishments, I would take up 30 minutes, so I'm not going to do that. I'm just going to say that she's the research director of CNRS Paris. She's a medical doctor. She's a parasitologist. At the same time, she's one of the world's leading historians of medicine, and it has been my privilege to have attended several meetings where I've heard of her work and have learned a lot from it. Her book, I mean, she has written many things, but her book, The History of the Adventures of Vaccination, is something that created new knowledge, which is always very good for academics, but also created new ways of thinking about vaccination, which generations of historians are benefiting from. I think it would be fair on Dirk if Thompson introduced Dirk, but I'm very grateful for Dr. Dirk Engels for joining us. This is a new format. It's a first for the Wellcome Trust Center, and as I was telling Thompson and Dirk, the reason we are putting historians and policy managers together is that we feel that it's important to get conversations going between the social scientists, and those involved in policy design and management. The more people talk, I think, the better our collective future. There is a lot we can learn from each other. It is not our intention at the Wellcome Trust Center to suggest that history only can teach policymakers. We are very keen to learn from all of you at the WHO about the things you do. So thank you very much for your support. Would you like to, Professor Anne Marie Moulin, will present a talk, after which Thompson will introduce Dr. Dirk Engels and his talk.
Yes, I'm going to ask Anne Marie to come and do her bit, and then if there are questions for her, we'll take those then, and then we'll move to Dirk. Anne Marie, if you're ready, we look forward very much to your talk. Thank you.
Well, thank you, Sanjoy, for these kind words, and thank you everybody for sharing lunchtime with us. Chasing the dragon. Is there a future for the Guinea-Worm? We hope not. It does not work?
It's not on yet. You need to play it.
Ah, sorry.
We can just...
Oh. I do it that way? It's better?
No, it's no problem. I'll just start this just now.
Just now. Okay, thank you. The Guinea-Worm is just one of the many names borne by a parasite which belongs to a family Dracunculiasis. The disease is typically marked by the emergence of one or several worms, sometimes, usually in the lower limbs, but sometimes in other places in the body, the eye, the tongue, the thorax. For this is, unfortunately, not only a kind of exotic oddity of nature, but it is a chronic, debilitating, incapacitating disease, mostly because of the frequent sore infections. These picturesque worms can be traced back to biblical times. We find worms in mummies. They are described by Alexandrian Greek medicine, and we have detailed accounts in Arabic and Persian medicine, for example, in the work of Ibn Sina in Canon, where you have a very precise description. Now, how historians can contribute to the management of international public health and the final solution of this disease. I think historians of science, medical historians, can illuminate, and it's important for WHO, the obscure link between scientific knowledge and decision. The history of the Guinea-worm disease is very long, as you can see there, and it's in striking contrast to the short 30 years, the recent years, which have elapsed since WHO targeted the elimination first, then the eradication of the disease. This decision followed smallpox eradication in 1979 and unsuccessful attempts to eliminate other scourges. Now let us talk about this tropical disease. Invisible in a way, although very visible. Little known of the Western public. Let us talk about a parasite which was dubbed by Carl Linné in the 18th century Dracunculiasis medinensis. We know a lot about this disease, and since the 19th century we have a fairly accurate idea of the cycle. Here the pictures by Alexei Fedchenko, a Russian zoologist who studied the disease in Bukhara, in one of its main seats, so early as 1868. Then the Cyclops. You all know how the Guinea-worm disease is transmitted. It's transmitted by drinking water contaminated by infected cyclops, and the disease is disseminated when people enter the water with wounded legs. That's the cycle. That's a contemporary landscape. Now, why Dracunculos medinensis? Dracunculus you have seen because of the winding, sinuous shape of the worm under the skin. It's this aspect which made people long time ago think that it was a living being, because obviously it moved, it crept beneath the skin. Why medinensis? It's because Sina called it this way. And it seems that Medina and Mecca were not necessarily the places for the infection. But in Medina and Mecca, which are the cities for the pilgrimage, the Hajj, infected people came to the pilgrimage for all kinds of different countries, and the disease was well known by travelers. The pilgrimage gives me the opportunity to explain how people get infected with images of the pilgrimage. You have to remember that people come in from all countries on a ship, that's picture at the end of the 19th century, then walking, you know, with the sun, and of course becoming very thirsty before reaching Mecca. And what happens? They see suddenly a pond, some water. Immediately the pilgrims rush to it, they bathe, they drink, and you can imagine how operated the transmission. Now it means that the disease appears, and it's very important, it's a truly Hippocratic disease, when the weather is hot and water scarce, and the vector lies in ponds and shallow wells. It means that the region, the elective region for this Guinea-Worm disease is mainly the tropical belt, the semi-arid belt in Africa. And people infect themselves by drinking water containing the vector, cyclops, a crustacean. They contaminated water by stepping into the ponds, and here you have one of the famous step wells. It's not in Pakistan, it's in India, to avoid that somebody comments. So infection had a seasonal profile. Because a long period is intercalated between infection and disease, around a year, transmission happens either at the end of the rain season in hot and humid countries, or in the contrary, at the beginning of the rains in semi-desertic regions. Which is important is to remember that you have this time which is elapsing between contamination and the emergence of the worm. And it means that because people are traveling a lot, because people are mobile, you can find infected people very far away from the place. So it might have been an obstacle to understand how the cycle functions, because in fact, people notice very early that there are kind of epidemics. It means that there are people who contract the worm, and usually it's cluster cases. And so people attributed it very early to the fact that they drank from a place where the water was foul, was not very pleasant. But they had no choice because there was no other source of water. But of course, because the people moved around the world, this infection was described by travelers all over the world, even in faraway continents like America. We had cases all over the world. But the transmission did not necessarily operate in this place because of some elements were missing. It seems that the disease out of the belt, the tropical belt of Africa and the Indian continent was never established, even although there was much discussion about the possibility of a transmission by animals, but the idea of a reservoir, of an animal reservoir, obviously was never established. It means that the perspective of eradication is possible. It's not easy. It was not easy to trace the cases and to understand how the disease was propagated. But very early, that's the important point from a historical, for historians, is the fact that before the full understanding of the cycle, people could make the difference between the fact that some cases happened, but the transmission was not necessarily happening locally. I will illustrate that by the Egyptian case. Egypt is usually mentioned as one of the endemic countries for the Guinea-Worm, but was actually Egypt really endemic for the Dracunculiasis. Claude Bey was a physician to the Pasha Muhammad Ali in Egypt. He described more than 100 cases when he arrived for the first time at Cairo in 1829. And here at the Abu Zabel Hospital, which was a military hospital, he described these cases and got accustomed to the disease and to the technique for curing the worm. That means local extraction. And Claude discussed the fact that all these cases shared something. They were not local cases. All these people, the soldiers, came from Sudan and or the Upper Egypt, and then they had probably become infected. And he noticed that as time went on, the number of the cases in Egypt decreased because for him it was linked to the wars in Sudan and to slavery. So in fact, his work on the Guinea-Worm, or the Medinacis, in fact was a kind of message to the Pasha. The Pasha had enrolled people from Sudan to make war, and he also brought some slaves in the army. So the disease decreased in Egypt with the end of conscription. The conscription both ways. The conscription from Sudan to come to the wars elsewhere, and the conscription of Fellah in Egypt to wage war in Sudan. I'm not sure that the message was heard, but it's clear that even from this period, they had doctors could make the difference between local cases and local transmission. Slavery played an important role because travelers, among travelers, slaves from Africa, disseminated the disease in 4 continents. It means that the disease was closely associated to water-linked human behavior. That's why my historical question is that why was the fight against the disease so slow to occur when we had more or less all the elements to stop transmission? I mean, it did not require any expensive and difficult technology. So that's a real question of my presentation. Local knowledge and local know-how were very important. People knew that the worm appears a long time after the contamination. They knew the best thing was to try to get rid, either by twisting it around a piece of wood or trying to extract it at one pool. They also know that it was a chronic disease, very incapacitating and painful. In this disease, doctors learned from the people. For example, I read Western doctors, Pollack and Schlimmer, who started the medical school in Dar el-Funun in Tehran in the middle of the 19th century. And they explain how they learned from Persians Hakim, and from Persian patients about Dracunculiasis at Tehran in the middle of the century. August Hirsch, in the pre-bacteriological era, who reviewed all documentation in the 1870s, concluded that at the end of his review, that the affection can affect everybody with no distinction. That's a kind of universal disease. Even if it's a tropical disease, it's potentially universal, with no distinction of gender, social class, race, nation, and so on. But In fact, that's true that this affection happens more often in men than women, with the poor than the rich, with adults than the old or the very young, in soldiers rather than officers, the black versus the white, the natives versus the Europeans. It means that obviously there is a strong social and behavioral component, and then it means it opens up a perspective for managing the disease and stopping the transmission. Yet, and that's my question, my query to you and to my colleague, why the eradication idea was launched by WHO and even slowly, only in the 1980s and even a little when they switched from elimination to eradication. The answer to this lag of time, this loss of opportunities, probably be found in what Dr. Johann Schlimmer thought of Guinea-Worm disease in Tehran in 1874, a disease which strikes countries far away from the capital, hardly raises any interest from scholars who possess the scientific tools, while they should pay more attention to the well-being of the suffering people. So how can questions from historians contribute to these problems of public health? I think typically historians question the link between knowledge and decision, and sociologists of science and anthropologists scrutinize the practices. We have seen the cycle. The cycle is something very simple, and in fact, when we look at the cycle as scientists, we get aware that there are many details we don't know. There are a lot of things we don't know exactly about the cyclops, about the traveling. When I used to teach parasitology to the students, they asked me questions about what is the destiny of the worm inside the organs, what happens during this long year when the male and female mate, and the female finally gets out of the body. I was unable to answer. I did not know so many things we don't know about the cycle, but yet it's possible to understand very simple things about stopping the transmission. But scientific knowledge is not enough. We have to make scientific truth appear desirable to the people, and communication certainly contrives to make them palatable and concrete, because resistance is not only a biological phenomenon. I think people also resist to change. Now, an ancillary question. There was an effort to eradicate the infection. It happened in Central Asia in the 1930s. And I asked the question, why did it pass unnoticed? This episode happened a long time after Alexei Fedchenko's description in Bukhara of the worm and the cycle with the role of cyclops. This strategy started with Leonid Isayev, who was a Russian doctor in Bukhara in 1925, a very difficult period from a political viewpoint. The strategy combined, firstly, counting the case number, which was difficult because it's a kind of intrusive procedure. The second measure was drying up basins and reservoirs. You here have a view of the Bukhara Mosque and its reservoir. And treating wounds with occlusive dressings. It involved a kind of fight against the local Hakim and Tabib who used to take care of the wounds, and the treatment of the wounds was with occlusive dressings in kind of outpatient clinics for free. Which means that contrary to the present WHO doctrine, it meant to fight traditional medicine. And in the context of the Soviet occupation of Central Asia, that was a feature which was far from being neutral. Health education of the young. This episode seemed to have resulted into the elimination of the worm in 1931. and it resulted into the publication of books celebrating this victory of communism and public health in the Soviet style in a very short time. There was a novel about Leonid Isayev called The Man Who Asks the Question. So and of course, for example, water carriers were forbidden to work because they, with compensation, say the papers. It means that in this social and political context, it's sure that the Soviet action probably fostered a lot of resistance in the country. You have seen the reservoir close to the mosque, and in this reservoir, of course, the Muslims perform their ritual ablution every day. So the fact of drying up the reservoir could be understood as a kind of fight against the local manners and the religion. Now, what happened when, and there we had to understand that our twin presentation are not the presentation of a historian and a presentation of a real doctor. I'm, in a way, a real doctor, and I think that Dick has something of a historian. Because, in fact, who knows about what happened in the WHO in the 1980? Of course, the people who were the actors of the drama. So it means that historians need to hear about what was. I think I had a hypothesis that probably turns to be wrong. I thought that the idea of the elimination of Guinea-Worm came in 1981 because it happened 2 years after Alma-Ata. For me, Alma-Ata, for the historians of public health, Alma-Ata marks an important landmark in the chronology of international public health. It meant the turn from curative medicine to preventive medicine, the call to traditional practitioner, a neologism coined by WHO. And Alma-Ata was also, in a way, the peak of the influence of the Soviets in public health, their last success. So the elimination of Guinea-worm and the fact that it was an environmental disease, the fact that it was a disease of the poor, was for me the key to understand why this decision was made. But as Dick will talk to you about, I think I was wrong, and it was something that did not mark a radical change, but probably more something which was coherent with what had been done in the previous 10 years with an effort to bring safe water to the people who need this safe water. So I think the influence of smallpox was probably important. WHO and the institutions promoting international public health were looking for a new candidate. And of course, it had been, they had considered other candidates before the Guinea-worm, mainly leprosy. I remember leprosy, tuberculosis, syphilis, yaws, a number, and malaria. Malaria, as you know, was a bitter disappointment. But it was certainly more glamorous than the Guinea-worm. But this choice was a kind of second choice. And I think clearly this change was meaningful for the people who had suffered from Guinea-worm disease. Because the problem with Guinea-worm is that it was not a medicalized disease. In fact, I remember the first time I met a case of Guinea-worm, it was somebody who had for a long time tried to twist by himself the worm around the stick. And he came to me saying, no, I'm in a civilized country. I want a doctor to take care of my wound. And I said, I'm sorry, I think I read in my books that it's very difficult to extract it, and I might break it. So please show me first, and I will do like you. So it's clearly, it means that this affection was not medicalized, that very few people went to a health center or to a doctor in the big cities. It was an
The broadcast is now starting. All attendees are in listen-only mode.
Disease. So this marked a very big change. And I think, which is interesting, is to know why this episode, which occurred in Uzbekistan in the 30s, was not repeated elsewhere. When you know, for example, after the Second World War, how there was a kind of race between the Soviets and the United States for polio, with the twin, the race between the Sabin and the Salk vaccine. So I think we have to understand how fighting is, in a way, contagious. I think the example of the Guinea-Worm disease illustrates how it needs to recruit the people, to convince of the importance of stopping the transmission. And here we have clear example of popular art. We have seen in Uzbekistan how poets, musicians, novelists contributed to raise the awareness of the public. For historians, I think Alma-Ata, which was perhaps the last great success of the Soviet Union, marked a beginning, a new beginning. I think, which is extraordinary about the Guinea-Worm disease, is that it has been always a popular disease, but very little medicalized. I think we need to have this popular art. And here are three examples of the popular art, which this popular art needs to encourage popular adhesion. Without the art, without communication with the public, we cannot hope to turn sanitary utopia into real and living stuff. We have to remember something I will share with Dick, is that I thought that eradication was a rhetoric necessity. Eradication has a nice ring to it. You can convince, you can electrize, dynamize people by talking about eradication. But in the case of a social tropical disease such as the Guinea-Worm disease, we have no choice. The eradication is not a rhetoric necessity, it's a biological necessity, because one single man sheltering a worm can recreate the disease. Thank you.
Thank you very much, Anne Marie. We'll invite questions on her presentation now, if there are a few. So feel free to raise your hand and offer a comment or a question if you wish. And if you would, and could be near a microphone, switch it on, and if you could give your name, that would also be nice. Thank you. Gentleman over there.
Thank you. My name is Marc Karam. I just wanted to bring some additional information to the speaker. She mentioned several times that this disease is not medicalized. In fact, there is no treatment actually for this disease. There are no drugs, no vaccines. And this explains a little bit how probably WHO was not eager to enter into an elimination or an eradication program at the beginning, as compared to other diseases where you had vaccines or drugs like malaria, like polio currently, or smallpox in the past. Having said that, the idea of eliminating the disease, if I'm not mistaken, started to take a real shape in WHO at the time where there was a launch of a worldwide program which was called at that time the Decade for Safe Drinking Water. So the people who were involved at that time with parasitic disease in WHO, it clicked in their mind that that was the opportunity, because if they missed that opportunity, they would not have any other mean. So they launched the program at the beginning, as you mentioned, for elimination. And I guess just to bring a little bit of precision, this is due to the jargon that was used at that time for eliminating disease. It was probably more fashionable and probably more discreet than going into eradication. Indeed, in the jargon of WHO, the use of the word elimination was more appropriate when it concerned only one region of the WHO, the Americas, Africa, Southeast. We couldn't speak of eradication if it happened only in one of these regions, because eradication, etymologically, it has the word roots, and eradication means removing the roots. So you can't speak of eradication when it's only localized to one region. You have to speak of eradication when it encompasses the whole world. That's why, I think in 1995, or a little bit earlier, they switched to a global program for eradication of Guinea-Worm. And that switch really triggered a lot of interest, as you mentioned. A lot of, you mentioned the word I can't remember, electrolyzed the whole community, the scientific community, to make a worldwide effort to really eradicate this disease. And as you said, as long as there is a single man infected, there's still a potential risk of resurgence of the disease. Thank you. Just a precision.
I don't know whether you want to answer. Is there anyone else who'd like?
I will first answer, if you don't mind. Thank you for reminding us that this disease was called the disease of all remedies. It means that in the ancient authors, I found so many recipes with all kinds of things, potatoes, beef, and many recipes which obviously turned to be ineffective. And there were some antibiotics and chemical drugs which were also used with very mitigated results. But to turn to the global thing, thank you. I think maybe because I had some training in philosophy, I was inclined to favor changes in ideology. So for me, Alma-Ata was a very important event because we turned our backs from curative medicine and turned to preventive medicine. But you are more pragmatic, and I think Dick, and you emphasize correctly the fact that it was more an opportunity because of the decay of water, and it afforded a unique opportunity to have money and to focus the important thing to have access to safe water. It was not an ideological change. It was to seize the opportunity that was showing up. So I think I was wrong in my interpretation.
Thank you. Is there another question? And if not, then we'll continue the discussion after our second speaker. In which case, I'd now like to introduce Dr. Dirk Engels to complement the presentation that you just heard. Dirk is coordinator of preventive chemotherapy and transmission control at the Department of Control of Neglected Tropical Diseases. He's a doctor in his own right with a theoretical training in epidemiology and a practical one in parasitology. He's a veteran of the field. He worked 15 years at least in Africa, successively in clinical, tropical medicine, public health and disease control before joining WHO in 1998. And I know that you've already met, the two of you, some years ago, and this is a happy reunion. I'm very glad that we brought you together. So, Dirk, it's now over to you, and after you, we'll have an open discussion. Thank you very much.
Where's the technician? Right, just close this. Thank you. I've called it Going for the Last Mile because that is actually what it is going to be. As you will see later on in this presentation, we're almost there, so we have no other option actually as to walk that last mile and get to the end of Guinea-Worm. Here you see a worm, the bad girl, because it are only female worms that you see emerging from the human body. Now, why is Guinea worm a good candidate for eradication? I've tried to summarize a few key characteristics here. First of all, it is quite a disabling disease. So there is a high perceived burden which makes it easier for people to adopt control measures that can prevent the eruption of this worm. It's an easy and unambiguous clinical diagnosis. That is why I wanted to show you the worm from the start. The human is the only final host, at least for Dracunculus medinensis. There are other Dracunculus species, animal species, but this is the only one infecting the human and with the human as only final host. The disease has a limited geographical distribution and is seasonal, as Anne Marie explained. And then the feasibility of success has been demonstrated in several settings. The interventions are relatively simple, effective and inexpensive. Although in public health, even the simplest is already complicated enough, compared to other interventions, these are relatively simple. And then also, and Mark nicely explained this, that there was a synergy of attack with other interventions, as the International Task Force for Disease Eradication calls it, and the opportunity here was that while trying to eradicate Guinea worm, you supply also safe water to the people, which has much more extended benefits, and vice versa. While supplying water, you also do something about Guinea worm. This is the life cycle. Anne-Marie showed it already, but I'm going to go a bit more into detail about where you can intervene. The first thing you can do is case containment, making sure that people do not get in the water and that you don't give a chance to the female worm to release its larvae and perpetrate the cycle. Second thing, if that unfortunately happens, you can do another thing, is to treat water with an insecticide to try to kill the intermediate host, which is a freshwater copepod. And then also probably a more effective measure is making sure that the water which a person drinks is free of copepods, either by the use of water filters or the more permanent solution, which is provide safe drinking water. Now, an important thing in the cycle is, and you see it up there in red, is that the duration is approximately 1 year. It takes about 1 year for the cycle to perpetrate itself. That is important because you always have to think 1 year in advance, or if you see something happening, you have to think 1 year backwards. Although you have to be on the ball, it's a bit as being on the ball in slow motion. Now, here I have summarized the set of interventions. I mean, one thing I couldn't show you in the cycle is the cornerstone of actually the eradication program. It's community-based surveillance to detect your cases early. And then intensive containment measures, safe water supply, the different elements, and health education to make sure that people follow your advice well, and that the implementation rates of each of the components are very high. Another thing I wanted to highlight, and Anne-Marie did already, is that Guinea worm now today is confined to areas of extreme poverty. Here you see an image of South Sudan. And here you see what people actually sometimes are forced to use as water supply because they simply have no other option. Now, let me walk you through the different measures with a number of pictures. Case containment, the idea is to spot, through community-based surveillance, to spot the cases at this level. Just before the eruption of the worm, there is a blister, and that gives a burning sensation which pushes people to get into the water to relieve this burning sensation, and then the worm erupts. So the idea is to get them at this stage before this happens, and especially before they get into the water. There is basically only one treatment, that is the traditional treatment, and often people, rural people, non-medically trained people do this much better than we doctors do because of the better practice, I guess. So it's bit by bit pulling the worm out, making sure that you don't break it, because then it's going to die and you're going to get third infection, which even makes the disability worse. But it will take quite a while, a number of days, sometimes several weeks before you can get the worm out. And in the meantime, it's important to bandage that person to avoid third infection, and especially to keep him or her out of the water. If unfortunately somebody gets in the water, and you know this, you can do copepod control, and here you see a microscopic image of the copepod, and you can kill the copepod with Temafos, or Abate is the product name. This is an insecticide which is harmless for warm-blooded animals, including the human being, which can relatively easily be applied in small water sources like this one, but it becomes a bit more of an issue, of a hassle, to do this in large water bodies like this one. This is done with the means that are available in those poor settings, and here you see a technician in Ghana applying this with the means he has. The problem is that if you do this along the borders, eventually the product will get to the middle and will kill the copepods. It's quite effective, but for the first initial period you have to also keep people out of the water, because these are concentrations that are much higher than the actually prescribed concentration. But it is a sort of damage control, but it can be very effective if you apply it systematically. A more permanent solution is this, of course, the provision of safe water supply in whichever way you want it. And here you see a few pictures of it. As long as it doesn't transmit the disease, it is fine. Or another one is actually using filtering devices. And here you see some of them who are systematically distributed to households in endemic areas. The idea is to fit them well on the containers and to filter the water that they collect through it, so that the drinking water doesn't contain copepods. Why did I put correct use? Because it may look simple, but it is not that simple. I mean, a lot of people use filters with holes in it, or use filters once this side and then the next time the other side, and wash all the copepods in their drinking water. Honestly, it is not that easy. Another thing which was developed was this. This is a drinking straw, because we also realized that there were a lot of people who did this quite well for water who they took home, but then when they were in the fields and they were thirsty, they just went to drink in the water sources. And this is a straw developed by a Danish company with just a filter at the end of it, so that if they aspire to the water, they don't ingest the copepods. Now, who are the main actors in the Guinea-Worm eradication program, and what did it cost? Now, the basic actors are, of course, the affected countries with as main international partners, and these are not the only ones. I have a slide with a list and you wouldn't even be able to read them all because the list is so long. But these are the main ones. There is the Carter Center, who is basically responsible for interventions geared towards transmission control. There is WHO, who has as core function the formal certification of Guinea-Worm eradication, and this is closely linked with surveillance, maintenance of surveillance, guiding countries through the pre-certification phase, as I will show later in the presentation, and more of a formal responsibility. And then is UNICEF, who is actually responsible mainly for the safe water supply within the program. Now, what did it cost? These are the most reliable figures I have, and very reliable figures actually. This gives you an idea of the external contributions for Guinea-worm eradication received by the Carter Center. This does not include what countries themselves have put, of course, which is difficult to evaluate, but these are external contributions. Mainly for operations, but we, WHO, have benefited also from these contributions and are benefiting even more of it with this last grant that was received for Guinea-worm eradication. So from 1987 onwards, we are about in the order between 200 and 250 million US dollars. That may sound expensive, but if you put that in another perspective, this is not even half of the budget for polio eradication for 1 year. That is just to give you the perspective. All in all, a cheap eradication program. And here you see the division by donor. The white figures here are the past ones related to these 145 million. These are the new ones related to these 72 million. So you see that the Bill and Melinda Gates Foundation has been a substantial contributor to past funding, and is also a substantial contributor to the new funding we have received. Under the form of a matching grant, they gave 40 million and they asked the Carter Center to match it with contributions from other donors for an amount of 32 million. Now, I guess the Carter Center will use its traditional donors to actually raise those 32 million. But this also gives us, WHO, a lot more power and financial means to implement our part of the program. Here you see the successive resolutions, and Mark has elaborated already on this one. It started in 1981, not really as Guinea-worm eradication, but taking advantage of the International Drinking Water Supply and Sanitation Decade. The two next resolutions were shyly talking about elimination, and especially this one, as a parasitologist, doesn't make much sense to me from a parasitological standpoint, because eliminating as a public health problem, what does that mean? Reduction of incidence, yes, fine, but if you want to prevent the disease, there's only one option, that is interruption of transmission, which should logically lead to elimination in a geographical area and eradication globally. And that is probably, as Mark explained, a bit of confusion between those two terms, which WHO has clarified since then. Fact is that the big push was given in 1991 with an almost impossible deadline of 95. Then in 97 there was a new World Health Assembly, and the final one calling for interruption of transmission by 2009 was called the Geneva Declaration. That was a resolution approved by the World Health Assembly when President Carter was here in 2004. This is what we achieved up to so far, since the late 1980s, and the fact which was the periods when most countries actually started a full-scale elimination eradication program. And you see that from 20 endemic countries, which I've pictured out there, we have gone down to 6 endemic countries, and from a number of cases just short of 1 million, we are now down to less than 5,000 cases. Now, a more detailed progress in the last 3 years, you see that in 2006 we actually had an increase, which was basically due to the fact that this was the first year that in South Sudan, the whole of South Sudan, or most of South Sudan, was accessible following the comprehensive peace agreement, and that in fact this corresponded more to a better detection of cases and a more accurate estimate of cases than the previous year, when most of it was still inaccessible. Now, since then, according from these figures onward, we have reduced by more than half in 2007, and again a 52% decrease in 2008. Here you see the 6 endemic countries and the progress they've made. Ghana has made tremendous progress and was even a bit frustrated the years before, because they kept on saying, no, we're doing our best, we're doing our best. And probably they have been doing their best, but we only saw it last year. Remember, 1 year, the efforts you do now, you can only see 1 year later. Sudan is making steady progress, but at a lesser pace. Mali actually is a bit of a problem because of these regular outbreaks, which are actually due to a lack of surveillance in an area where there is periodic insecurity, and where all aspects of the program cannot always be implemented. Now, these here, Ethiopia and Nigeria, have been outbreaks, and Ethiopia even after quite a while of 0 cases, but which have been very rapidly contained with very high case containment rates. So we're quite confident that they will actually quickly get back to 0 cases again. Niger, well, I think out of the 3 cases there was 1 or 2 imported cases. So we're not too worried for these 3 countries. The main challenge actually is here. If you look at the case containment rates they have reported in 2008, you see that Ghana has moved up to very high case containment rates. Mali reported high case containment rates. If this is true, we logically should see a decrease in cases next year. So we're anxiously looking forward to that. Sudan, even if they're making steady progress, the case containment rates remain relatively low. And here, as you see, some of them are very high, so that is in good order. Then this is hot from the press. In January, February of this year, there were 122 cases reported as compared to 257 last year. So we have again a 52% increase. Apparently we're on the right slope as long as we can maintain it. Now this is quite some elegant work done by Dr. Ahmed Taye, and he published that in the Tropical Medicine and International Health. This actually can give you an idea of how long it may still take. The issue is not if, but when, as I said in the beginning, but how long can it still take? And Ahmed, has analyzed how a number of countries have performed who have gone to elimination on their territory. And you see from the point where they started a full-scale program and the number of cases they had at the start of a full-scale program. Now this is a logarithmic scale that has an advantage. If you try to do the best line, draw the best line through this, it gives you actually the average of what the countries have been working against. And the average is about 42% decrease in cases per year. Now, The better pupils are on the upper left, the lesser pupils are on the right lower side of this line. And if I can take one example of a good pupil, that is Pakistan. And Pakistan had when it started, and I think that was 89, Ahmed, is that correct? When it started, it had a similar number of cases as Ghana had in 2007 and Sudan had in 2008. Now, Pakistan, here you see the decreases year by year that Pakistan has managed to obtain. And you see that sometimes it was 70, sometimes it was 30, but apart from this 34, it was always above 50%. In this way, Pakistan has managed to gain 2.5 years as compared to the average. Now, if you compare that to our two best pupils today, Ghana actually is above that. So if Ghana can maintain a reduction in this order, it will actually be able to do much better than Pakistan, who still did 6 years from where it was then. On the other hand, Sudan is more or less according to the average, and if they continue to maintain the same performance, it will take them most likely another 8 years before they get to 0 cases. So this is to show you that yes, we are almost there. Yes, we're contemplating this last mile, but the last mile can still be a bit challenging. And what are actually the remaining challenges? I'll show you a few of them. This one, for instance. Ethiopia has had 0 cases for more than 1.5 years, more than 18 months. And then suddenly an outbreak, probably imported from South Sudan. Yes, but due to a lack of surveillance. Now, we expect that this will be relatively rapidly be contained. The issue in Mali has been a bit more complicated and a bit more complex. You see here all these cases actually are an outbreak in a new area, in the Kidal area, and this was basically one person, a pilgrim who decided to walk to Algeria and got blocked in Kidal because of an eruption of a Guinea-Worm and infected a number of water sources. 1 year later, we had an outbreak. This is the second year with, well, 2008 was the second year with a substantial higher number of cases. And even there were now cases reportedly having gone into Algeria. We have no detailed news yet, but next month Dr. Taye is visiting Algeria, well, Dr. Taye and Dr. Karam, and they will try to find out what exactly happened and whether there is potential for local transmission or not. These are two international examples, but you also realize that this happens at all the time also at a more macro level. In this area, for instance, so villages who have been freed from Guinea-Worm, who remain 1 year free and then get reinfection. And in fact, these keep on going round in circles. So the key activity that we absolutely have to reinforce is surveillance, so that we make sure that those villages are protected and that at the slightest case that everything is put back into place and that proper case containment is being done. This is the only way through which we can accelerate the progress towards 0 cases. Another major challenge, of course, is this, and war is Guinea-Worm's best friend, because then, of course, the key to success is high implementation rates. War disrupts everything. We are making good progress in South Sudan since the comprehensive peace agreements. There are elections, I think in 2011. You've seen in other African countries what elections can bring about, so we cross our fingers that this may be okay in Sudan and that we can progress further towards eradication. I also told you in Mali in that area of Kidal, there is periodic insecurity which sort of stalls the implementation of the program. Now I wanted to end with WHO's specific responsibilities in Guinea-worm eradication. That is basically pre-certification and certification, and then sort of directly related to that reinforcement of surveillance in Guinea-worm-free areas in countries who are still endemic, which logically leads to good overview or good surveillance during the pre-certification period. The pre-certification period is minimum 3 years, more in countries neighboring still highly endemic countries like South Sudan, of course. And this starts with the setting up of a national certification committee, continued and extended surveillance, trying to make your surveillance very sensitive by a reward system. That is one option. Also trying to keep an eye on how effective your surveillance is, registering all the rumors, making sure that all the rumors are investigated, and then conducting ad hoc searches wherever that is necessary. Then certification is the formal process, which is the final phase of the pre-certification period. Starts with the verification of the capacity of surveillance by an international team, and then eventually, just before the dossier is submitted to the International Commission for the Certification of Dracunculiasis Eradication, the ICCDE, a visit by an international certification team who backs up the request of the country, and if that is approved by the Commission, then they advise the DG to grant certification to that country. Now, where are we in terms of pre-certification, certification? About 180 countries have been certified so far, including 6 of the formerly endemic countries, which you see listed there. 8 countries are currently in the pre-certification stage. You can see them here. And I have painted in blue the ones we expect to certify in at the end of this year. In October there will be another meeting of the ICCDE. 6 countries have not yet interrupted transmission, and there are also a number of countries who have never actually had Guinea-worm, or who have not had it since a long time. For this, certification is less complicated. A country like South Africa, for instance, it's basically a questionnaire and a thorough examination of the capacity of local transmission. For the Democratic Republic of Congo, it may need a bit more work and going and seeing whether actually there is no transmission potential or has never been. So that is more work. Now here you see the map of where we are. Cambodia here is a lonely outlier. Brunei is another one, but you can't see it here. So we hope to certify most of these countries in light blue rapidly, quickly. Certain countries like Kenya, for instance, may need a longer period to certify because of the danger of exportation of cases from Sudan. So we have to weigh actually the efforts of a country against the danger of reintroduction. And I wanted to end with this. This is a typical picture of an area of a site where Guinea-worm is transmitted. And you can also see there our recently revamped website in which you can find more information if you want to. Thank you.
Thanks, Dirk. I'm now going to ask Sanjoy to come back in and to chair the discussion, which we now open up to you. Thank you very much. Thanks again, Dirk.
Well, thank you, Dirk, and thank you, Thompson. Please.
I just want to comment on Marianne.
Could you let us know your name?
My name is Ahmed Tayah. I want to comment on Marianne's statement that the scientific knowledge and tools are available. Why the international community or the WHO haven't taken action and start eradication. I think probably because of the experience of malaria, and also because eradication is not easy. I mean, in order for eradication to be called eradication, it should be short. Now, until now, we have 30 years from 1980. Now, after 30 years, we need more 10 years to finish. So it is not easy. And why it's not easy? Because I think the intervention are sound. We don't have problem in the intervention. But to apply the intervention in a certain setting, probably in Bukhara and Iran, the situation was different because of they have a kind of burqa where they know that people take water from this place, and while in the situation in Africa where you have near each village, and you have thousands of villages, you have water source, and the contamination is more widespread, and people move more frequently. So I think, I mean, the experience of eradication is not easy, and as Henderson said, after finishing the smallpox, why elimination and control is a bad word now. I mean, to have eradication, you have to be quick, to do it quickly. Otherwise, it's not called eradication. So it has problems. And now we see that people want to eradicate malaria. So it's becoming fashion that let's go for eradication. And so it means we are not learning from history that eradication is difficult and it may have setback. And even now, some people for polio saying, why eradication? So we have to think about really, one really wants to use, I'm sure somebody now trying to eradicate another disease, but it's not easy.
Could it be perhaps because it stokes donor interest when you use the word eradication, that it's easier to raise money?
Yes, but then you drag the whole organization and the whole community into this word, and then there is a very good side for it and a very bad side to it. So you dominate the Ministry of Health and you tell them this is the priority disease, but to whom is the priority? To the people or to the organization or donor or partner, or I mean, I'm hearing now from some colleagues that why you are trying to eradicate this disease? Why you are spending all this money on this disease? So there is views, very views. Is this disease, which I am involved in it, I am proud to involve in it, and I believe in it, but is it a public health problem? Is it how many persons it has killed? So to pick a disease which is not a public health problem and then eradicate it, it's okay, it's good. But then, you know, it has taken a long time and it will take more time. So this is like a debate. I'm not criticizing really. I'm just trying to see should we really go for eradication for other disease, just to learn from history. I think it's important.
Thank you very much. Alan?
Alan Schnur. I worked in smallpox eradication many years ago. One comment and two questions. The comment that I think one of the lessons of smallpox eradication is that the major beneficiaries are the poorest people. Mm-hmm. If we hadn't eradicated smallpox, you would still have no cases in Stockholm and Geneva and London. There would be cases in the poorest villages where there's no vaccination. So the inequity issue eradication does serve the poorest and the most disadvantaged. Two questions. For the end of smallpox, there was a lot of research going on to find potential gaps, and the virus, in this case the worm, is fighting for survival. So it will find any gap in the work, it will then find a way to continue there. So in terms of the lessons from Bukhara, probably in the final stages they had problems, they had breakthroughs. Have you studied that to get some idea for your end game for the global eradication program? Second question, smallpox at the end moved to a definition of outbreaks as opposed to number of cases. It's a big difference to have 30 cases around one waterhole as opposed to 30 cases scattered throughout the whole country somewhere. Have you considered moving to an outbreak definition?
Thank you. And you're directing this at both the speakers? Yes. Anne Marie, would you like to? Well, you can.
Yeah, it's true that for Bukhara it was easier because of the reservoir close to mosques, and it was very different from the landscape in Africa where you can have ponds almost everywhere after the rain. But I think the infection rate was very high because precisely when they investigated the old Bukhara and the old part of villages in Uzbekistan, they found, it seems from Leonid Isayev accounts, they found sometimes a infection rate up to 30%. So it seems to me to be very high. That's an answer, and I think an answer to both. You ask also the question, what happened after 31, and honestly, that I know very little. I think the situation in the Soviet Union during the Second World War was very chaotic, so I don't know what happened. Certainly the surveillance had other problems as the Guinea-Worm during the Second World War, and I don't know if there was some epidemics in the region. But interestingly, I talked to some people from Uzbekistan in Paris last week, and interestingly for the study of mentalities, and I said, oh, I'm going to Geneva to talk on Guinea-Worm, and they said, yes, you know, it's Avicenna who eradicated the disease in our country.
Thank you. I'll let Dirk answer.
Yeah, first of all, your question of the outbreaks, I do not understand it very well, but it has probably to do with the dynamics of the disease. Yes, there are these outbreaks of Guinea-worm reintroduction or introduction in a new area, leading to these outbreaks as we've seen in Kidal, as we've seen in Ethiopia, but that is, I mean, as a concept, no, we don't see it as a concept. I mean, we move gradually down from line-listed data of villages to line-listed data of cases as the number decreases. And in the end game, it's almost a follow-up of individual cases and making sure that a case, if it got into the water, that control interventions are built around that. So I do not really understand that whether it would make sense to go for outbreak, but maybe you can comment further on that. The issue of operational research, well, so far we are making good progress, and sort of operational research is only in the back of our mind. But this being said, we may not actually exclude having to jump to operational research if that was required. And I just want to highlight one example. 2 years ago, I think it was 2 years ago, we had this report from Ghana, a potential resistance of copepods to Temefos. And Dr. Ichimori, who is working in our vector control team, went there to investigate that further. And in fact, she realized that operationally it wasn't really an issue, and there were a lot of confounders, but still, when she did the tests in the laboratory with very limited means actually, there could be, I mean, at the normal doses, there were less copepods actually who died than expected. So this gives you an idea. It was a sort of false alarm, especially operationally, and most of the flaws were in implementation of the Temafos application, as I showed you that picture. But still, we keep it in the back of our mind, and it is never excluded that as you go towards the end, you may run into a problem. Although I must admit that we know surprisingly little about the transmission cycle of Guinea-Worm. We're moving towards eradication, and to be fairly honest, we know little about it.
Would you like to respond, Ellen? Or?
The others want to speak, but in terms of infected villages, an outbreak with number of infected villages or foci of the disease would be a lot smaller than 3,000, I suspect, because that's really the interest is waterholes or infected villages. But if there's 100 people in that village, it's still one foci.
Could you please also mention name for the record for everyone?
Hi, my name is Teresa Garcia, and I work in IT. So I had nothing to do with the medical world. But I just want to ask, where does this worm got its name from? Guinea.
I'll ask Adam.
I think there were a lot of travelers from the coast of Guinea or the Gulf of Guinea who has Guinea worm, went to Europe and have the Guinea worm after 1 year. So probably they say from where you get it from Guinea, so they call it Guinea worm, which is this is probably.
In fact, I read in one of the articles that the name came actually during the slave trade. A number of people were exported to the Americas, and most of them came from the Gulf of Guinea, and they had Guinea worm who erupted on the other side. I read that the name came there from, therefore they refer to it as the Guinea worm, referring to the Gulf of Guinea.
Actually, they were probably cheap from there, but coming from all over the place. And in that same, taking that topic, the slave trade, how come there is not in the Americas that disease?
No, please do.
I think there was probably a small, 1 year transmission or more in some countries like Cuba and Grenada. So there was long ago, 100 years ago, but then it stopped because the condition is not suitable for it to continue, because probably people drink from different sources, not the second. Mark also can.
Actually, you're right. The last cases reported from the Americas was in Cuba. But these were people from Ghana who went to Cuba, and the worm came out there, but there was no local transmission. It was not because the conditions are not there, because safe drinking water is available. There are no ponds like in Africa. It's not the same biological. Yeah.
We know there has been in the Americas, and just for an anecdote, we've been looking for a map this morning on an historical map showing that there have been cases in the Americas, but we couldn't find it.
I think the most lengthy report on that is the article by Susan Watts. She has a long article in Social Science and Medicine on the cases in America, and she talks about Guyana, Grenada, Cuba, and it seems there was never any case of local transmission, and when there was a cluster of cases, it was cases who had come on the same ship.
Thank you. Human, please.
Well, just going back to the concept of eradication, I mean, when we talk about other kind of species, we in fact preserve. We don't want to eradicate things. You know, we have endangered species, threatened species. Obviously, we're talking about a medical parasite, but it seems to me that, you know, this is a complex organism of which we know very little. I mean, the fact that there's no chemotherapy for a worm that obviously must have many points where you could have, it shows how little it is understood and known. I was just wondering if any plan has been made to sort of preserve this worm if it is eradicated, so that, you know, the useful things about this worm to society don't get lost in our zeal to eradicate it.
Well, we have frozen examples, of course, which we can keep. Now, to keep it alive in the cycle, I think is no options. Although, a few years ago, we have been contacted by an association in the US who actually blamed us for trying to eradicate a species and decreasing the genetic diversity. To which I quite cynically answered that if they wanted to keep the cycle alive in their community, I would be welcome to provide the larvae, and I never had an answer.
Sir, could you please mention your name as well, and then Madam?
Sorry, my name is Hazem Tamimi. First of all, thank you for a really interesting presentation. My question, you mentioned that the role of community surveillance was really critical as part of this effort. My question is really, once the number of cases has dropped to almost zero, how long does the surveillance have to continue for, and what measures do you have to put in place so that that surveillance continues? Because if people's memories are short, you know, you can imagine after 5 years, whoever people you had trained may not be on the lookout for new cases. So what are your plans in that direction?
Sorry. Well, you put the finger on exactly our big challenge for the future until we have eradicated it. That is strengthening of surveillance. And how would I say? Surveillance is not the same everywhere. Of course, you have to set up a sensitive surveillance system at the national level. But you also know that the risk of introduction or reintroduction of the disease is different from area to area. So the whole challenge is based on whenever you free a village from Guinea-Worm, I mean, it's, how would I say, it's giving different priorities to different areas in surveillance. Now, once you freed a village of Guinea-Worm, you can maintain the infrastructure which is there of volunteers, although it's difficult after a number of years to continue to motivate them to report 0 cases, obviously. But then the idea is to have regular reports of rumors and investigation of rumors, both at the local and at the national level, to get the attention going. Another option we're exploring now, and we're trying to implement actually, is linking with other means of surveillance, polio surveillance, integrated disease surveillance systems. That is done for the more, how would I say, the lower risk areas. But it is clear that high risk areas, just around areas where there is still Guinea-worm, you need to maintain the same infrastructure for a while. You can't do that logically over all the country. That would become totally too much expensive, but you have to carefully weigh off the opportunities you can use here.
There are actually a couple of audience questions that have come in through the web, and I think this is very exciting. And since we're experimenting this new system, I think we should direct these questions at you. So, Professor Gilberto Hochman from Fiocruz, Brazil, asks Anne Marie, is it possible to think that the concept of eradication also has a historical construct? And he adds, congratulations to the speakers and organizers, and I think he wants to congratulate you as well for helping us put this webinar concept together. So,
thank you to Gilberto for the question, the compliments and the question. But the question is difficult, but I think Professor Taye has answered to it, because he discussed the fact that the eradication is maybe glorious, but also very demanding. So obviously he advocates the fact that we should be very careful because it is a fashionable term, but it can also become obsolete. I think we overused the word eradication in the past. When I was a student, we talked about eradication of so many diseases which are still very well with us. And it has also a bad consequence. For example, many people think that syphilis, for example, had completely disappeared, and not ordinary people, academic scholars at the university frequently told me, oh, syphilis, of course, a 16th century epidemic, while we all know that it's not a 16th century epidemic. So it means that eradication can also be a smoke screen. And so, of course, a historical construct, no doubt about it. But we also have to be preventive in avoiding that eradication is a blanket word.
Well, we have another question from India. This is from Vivek Neelakantan. And he asks, I would be grateful if someone could suggest books related to the influence of regional political cultures on health. And Ian Roberts of the WHO has already sent him the information about two books. One is Culture, Health and Illness by Cecil B. Hellman, and the other one by Richard Skolnick, called Essentials of Global Health, published in 2008. But if there are any other books you would recommend to Vivek, I'm sure he would be very grateful since he's logged in.
A book on what?
On regional political cultures on health, the impact of regional political cultures. So perhaps he means regional politics and political systems on health. Yeah, we can follow up later, as Tony informs me. I think we need to bring this to a close because this room is going to be used by other colleagues. Thank you very, very much to the speakers, and thank you to the audience for joining us. And thank you, Tony.
That's fantastic. That's wonderful. Great experiment.